So good morning to you all, and at the outset my sincere thanks to VCare, ESI and Maharashtra team for giving me this opportunity to be in front of you today. And the topic given to me is fallacies in interpretation of the thyroid function tests. So nothing to disclose. And I think before learning on the difficulties in interpretation, so we have to have a sound knowledge on the how the normal hypothalamo-pituitary thyroid axis works. If we can understand, then and like hypothalamus TRH we all know, and we have been learning from the MBS onwards, and from the pituitary TSH, and working on the thyroid producing T3 T4. So there is a feedback regulation, so any minor changes, minute changes in the T3 T4 levels will be conveyed to the pituitary or hypothalamus, so drift change in the TSH levels. So and not only that, like thyroid hormones will be transported, like circulated, binding to the proteins TBG, albumin and transthyretin. So any changes in the binding globulins also will have an influence on the thyroid functions. And like you can see in the picture, the various hormone receptors, and one thing I would like to focus upon, T3 at the brain, so MCT3-8. So that, like, we have a case, like very rare genetic disorders where the deficiency can have a profound influence on the functions, thyroid functions. So I think this is very straightforward. Even MBBS student can answer. T3 is low, I think on the left side. T3 is low and T4 is low and TSH is very high. So it's a straightforward answer, hypothyroidism, right? T3 is elevated, T4 is elevated, TSH is suppressed, that is, so which is a concordant change. Concordant change with respect to the T3, T4 and the TSH level. So that is hyperthyroidism or thyrotoxicosis. And this is little just in the evolution of the hypothyroidism. This is a normal on the left side, and you can see the subclinical hypothyroidism where T3, T4 are normal, TSH is mild elevation, and further progression will cause a T4 will be decreased first, T3 will be maintained normally, and TSH further increase in the TSH, all full blown or overt, like full blown picture of a hypothyroidism with the T3, T4 being low and TSH is elevated. And similarly, you can see the subclinical thyrotoxicosis where T3, T4 levels will be normal but TSH is suppressed, but subsequently T3, T4 go up and TSH will be suppressed. Very rarely we come across T3 toxicosis also, where T3 alone will be elevated, T4 will be normal but TSH will be suppressed. So this is like concordant and with which is correlating with the clinical picture also. We are happy in making a diagnosis and appropriate treatment. So the problem, sometimes it can be confusing and it can be challenging to make a right decision for our patient. So I think would like to speak upon some of the case scenarios so that you can understand it better. So I think this is one case scenario. Look at the thyroid functions. T3 is low and T4 is low, but TSH is normal. See, what we have seen, T3, T4 low, TSH will be elevated, that is hypothyroidism. But here TSH is normal. So I think with the same laboratory report, I will give you two scenarios, how would we interpret. So in one scenario, with the same reports, 48 years old man was admitted with acute appendicitis and sepsis, underwent surgery postoperatively on inotropes, and was evaluated for thyroid in view of the small goiter. Okay, so this is one scenario. So another scenario is with the same laboratory report, 54 years old man with previous history of pituitary surgery followed by radiotherapy comes for the regular follow-up. So I think it's very clear from the scenarios. So that's why in interpretation, the one important thing is the clinical context for which the thyroid functions were done. So if we know that, we can analyze the TFTs in an appropriately and manage appropriately. So in the first case scenario, it's a non-thyroidal illness, so where treatment is not required. Whereas in another second scenario, it's pituitary surgery and radiotherapy. So it's a central hypothyroidism. In central hypothyroidism, T4, T3 will be low, TSH can be normal or can be low or can be little elevated. So that's why the background history will help you to make an appropriate decision with respect to the interpretation of the thyroid function test, so that you can make an appropriate decision whether to treat or not to treat, whether to worry or not to worry, or reassure the patient. So just a little theory on the non-thyroidal illness, how does it have an influence? So depending on the severity of the illness, how the changes in the T3, T4 and the reverse T3 and the TSH. In the mild, so it's an adaptive response basically. When the child, like patient is in a stressful situation, so we would like to bring down the metabolism. So peripheral conversion will be first impaired. So what are the, like deiodinases, D1. So D1 will be decreased. So D1 is involved in the peripheral conversion of the T4 to T3. So there is a decrease in the free T3, normal free T4, and reverse T3 may be normal, may be increased in the initial stages, and TSH is normal. So that is the mild. But as the illness progresses, severity increases, there is a further decline in the T3, free T4 can be normal or little increase, and reverse T3 is increased. This is because of the D3 activity will go up. Deiodinase 3 activity will go up, and in the severe illness, further drop in the T3 and free T4 also will come down. So as I have shown in the previous case scenario, T3, T4 low, and reverse T3 increased and TSH will be further low. So again giving a central hypothyroidism picture. So that's why background history or the clinical context for which thyroid functions tests were done are very, very important for you to appropriately interpret. And during the recovery, look at the recovery. So T3, T4 will be low and TSH will be going up. So this is giving again a picture of a central hypothyroidism. So this is on the thyroidal illness. So this is another case scenario. 20 years old primey, 14 weeks of gestation, was referred in view of abnormal TFT, had morning sickness. So T3 is increased, 2.2, and T4 also is increased. TSH is suppressed. So I think what is the diagnosis? How are we going to manage? So because I think this is common scenario and we do get referrals from the obstetricians for this abnormality. And another case scenario is similar. 34 years old woman was evaluated for thyroid in view of the hair fall, and no symptoms or signs. She was absolutely fine. No symptoms suggestive of a thyrotoxicosis, and has no goiter, was using some medication for the hair fall over the counter. So again T3, T4 are elevated, TSH is suppressed. Look at the TFTs which are similar, but the background scenario is little different. So in first case it's a physiological change because of the pregnancy. I'll come to it. So in the first case it's a physiological change where woman doesn't require any treatment, just reassurance and follow-up. In another case it's a biotin interference causing a picture of thyrotoxicosis. So what is the clinical clue? She did not have any features, either symptoms or signs suggestive of a thyrotoxicosis. That is the clue. And another clue is most often over-the-counter medications for the hair fall contain biotin. Okay, so this is, which I am going to discuss. So this is the physiological adaptation in pregnancy. You can see in the picture. So in the early pregnancy, there is a rise in the HCG peaking at somewhere around 14 to 16 weeks of gestation. Because of, and you all know, HCG and TSH has a structural similarity, so can stimulate the TSH. So little rise in the free T4, again having a feedback at the pituitary, so causing a decrease in the TSH levels. So that's what happens. So in the early trimester, somewhere around 10 to 14 weeks, there is a decrease, low levels of TSH, which can be to the tune of 0.1. Okay, so and look at the TBG. So because of the hyperestrogenic stage, there is a rise in the TBG, so which can increase the total T3, T4 levels. So in the somewhere around 10 or 14 weeks or 16 weeks of gestation, there is a total T3, T4 increased, TSH is suppressed, giving a clinical picture of a biochemical thyrotoxicosis. So that's why you have to have a clear understanding. And coming back to our case actually, so like see, suppose if you encounter T3, T4 elevated TSH suppressed in a pregnancy, so it can be physiological or it can be Graves also, or it can be gestational thyrotoxicosis also. But how do we differentiate? When do we consider this is abnormal, this is not physiological? So there is people more often go for a free T4 assays. I think I personally would not recommend to go for a free T4 assays during the pregnancy because the equilibrium dialysis, which is very cumbersome and not available at all centers. And one more thing is, with the T4 also you can make a good judgment. So if the T4 levels are more than 1.5 times the upper limit of the normal, then you consider it abnormal. So here look at the, actually 12 is the upper limit of the normal. So if you take 12 is the upper limit of the normal, 18 would be normal, up to 18 T4 is physiological. Right, 1.5 times the upper limit of the normal. Okay, so that's why I said this is physiological, and you also see the presence of a goiter, any eye manifestations. All those things will help you to differentiate between the Graves versus the physiological. And one more thing is, in the gestational thyrotoxicosis, you have again background history, like a hyperemesis gravidarum, or a twin gestation where the HCG levels will be much more higher. So, and it's a non-autoimmune disorder which is self-limiting. So that's how you make a difference. So in that scenario which I have told you, that's a physiological change. So just reassure the patient, nothing to worry, it will come back to the normalcy. And in the second, I am going to discuss on the biotin. So this is just to summarize on the effects of pregnancy on the thyroid physiology. So there is an increase in the TBG because of the hyperestrogenic status. So which is causing an increased T3 and T4. And increased plasma volume, so total pool size increases, so increased cardiac output will give some features suggestive of a thyrotoxicosis. So and increased D3 expression, so more T4 production, more demand on the maternal thyroid gland, and because of the first trimester increase in the HCG, so little increase in the free T4, in turn causing a suppression in the TSH, and iodine clearance will be more, so more iodine requirements. So these are all the changes which have an influence on the thyroid functions. So this is coming to biotin interference. So it's a vitamin synthesized in the gut and available in the food. High biotin doses are used in some of the rarer disorders like multiple sclerosis and rare metabolic disorders. So as a dietary supplement for the alopecia also. So the important thing what we have to understand is biotin can have an influence on the TSH as well as the T3, T4 estimations. And so look at this in the sandwich immunoassay, that is the IRMA technique, like where 2 antibody technique for the TSH estimation, which can cause falsely low values. And in the competitive immunoassay for the T3, T4, which can falsely elevate. So that's why clinical clue is very important. See, most often people will think that endocrinology is just laboratory diagnosis. It's not. Laboratory is important, but the clinical interpretation, clinical analysis together with the laboratory interpretation, that will help us to arrive at a proper diagnosis. So it's the knowledge what we have gained, it's a skill how to interpret the background situation to the laboratory parameters is very, very important. So that's where the importance of practicing the medicine. So this is another common scenario. I think this is a common scenario what we come across in our practice. So abnormal TFTs, when to worry and when to reassure. So I think similar TSH values for the 3 scenarios. One is the 32-year-old G3, so gravida 3 with 2 abortions. 10 weeks of gestation, was evaluated for thyroid and found to have an abnormal TFT. So T3 is normal, T4 also is normal, TSH is little high. So T6.5 anti-TPO positive. So just to keep aside the anti-TPO antibodies positive or negative, but look at the another scenario. 32 years old woman was evaluated for obesity with sedentary lifestyle and BMI being 32 kg per meter square. Again similar picture with TSH of 6.5. So the value is the same, but the background scenario is something different which is helping us to make a right decision. So, and another scenario is 72-year-old woman on routine health checkup found to have a TSH of 6.5. Okay, so what will we do? So, any postgraduates are there? So, I think this is, so in pregnancy, generally we treat, right? So this is the, actually American Thyroid Association guidelines are there, but like Indian Thyroid Association guidelines, so 2012 they are there, but no revision after that, but there is a, in 2019, like ITS and the FOXI has come to frame a consensus guidelines. So this is as per them. So management of subclinical hypothyroidism in pregnancy, anything more than 10 should be treated, that is very, very clear. So when it is less than 10, what should be done is a guideline. So patients with subclinical hypothyroidism to be started on 50 to 100 micrograms per day, and it is recommended when a woman, pregnant woman with more than TSH 10, so and antibody positive, irrespective of the antibodies, but and TPO positive women in between 4 to 10, so should be treated, but you can consider when the woman is in between 4 to 10, if the antibodies are negative. Okay, so in the previous scenario, so there was a 2 pregnancy losses. So we like where we do not want like to have any other impact on the pregnancy. So it is the individual like discretion at the endocrinologist or treating physician. So we would err on the side of the treatment. Whereas coming back to our other cases, so there is a ample evidence to say that like when the obesity like higher the BMI, so little higher value is the TSH. So it's not, and many people will blame that a little elevated thyroid for their weight gain. So it's not the other way around. So you have to explain them for little rise that will not cause so much of a weight gain. Okay, so that we have to explain. So here no need to treat that. And again, elderly women, aging have an influence. So higher the age, little higher value. So and most often they may not progress to overt hypothyroidism. So just watch and wait appearance for these 2 scenarios and repeat the function test. So okay, and again this is common scenario, discordant TFTs on levothyroxine. See, hypothyroid patients on levothyroxine coming for the follow-ups. So this is one such case scenario, 15-year-old girl, known case of hypothyroidism since 1 year, on levothyroxine 50 micrograms. In the follow-up, TSH is high and T4 is low, that is uncorrected. So what do? We ask for the complaints. If they say, if they deny complaints, we increase the dose. So that is being done 100 micrograms, and again next follow-up also showed, so again uncorrected state. So requiring higher dose than the usual. So how should we approach? So when such, I think these are all the common scenarios. So what would be the causes and how do we approach? And another case scenario is 46 years old woman with primary hypothyroidism on levothyroxine 100 micrograms, again on the follow-up uncorrected. So here T4 is upper limit of the normal. In the previous cases T4 is little lower limit of the normal. Here TSH is much more higher. So how do we manage this case? So when the TSH is high and T4 is low, consider non-compliance. I think most often it is non-compliance or maladministration. What do we mean by maladministration? Like having the tablet and having the coffee or tea immediately, or taking any proton pump inhibitors or calcium iron supplementations along with that. So you have to check for all these things. Or it can be a malabsorption, or it's increased thyroid hormone metabolism because of the associated drugs like phenytoin or enzyme inducers. If the patient is on newly started on any enzyme inducers, it can cause rapid metabolism and increase in the demand for the hormone. So our change in the LT4 preparation, I have seen so many cases like this. So I think many of you might have experienced. Change in the preparation also has an influence, because all the preparations, thyroid preparations, hormone preparations are not the same, do not have the same bioavailability. So I think these are all the things which we have to consider, and when we are not clear with the malabsorption and the maladministration or the non-compliance, we can subject for the thyroid absorption test. So thyroid absorption test is where like weekly dose is given like in front of us, patient has to take it, and subsequently for 1 hour, 2 hours, and we will be monitoring for the T4 levels, and subsequently at the end of 1 week also. If the levels are as per the, in the sense rise, there is a calculation to be done. So if that is satisfying that, like if the free T4 count is increasing, so then we assume that it's a non-compliance. Then accordingly we have to advise the patient. So in another scenario, so TSH is high but normal T4 are little upper limit of the normal, so you have to consider the assay interference. So heterophilic antibody interference. So this is the picture showing it can be have a positive interference, heterophilic antibody, or the negative interference. So this is like one more case scenario, a 20 years old woman with hypothyroid on levothyroxine 75 micrograms on follow-up. So T4 is elevated, 17.5, TSH is 5.5. So what should be our advice? So TSH is little normal or upper limit of the normal, but T4 is high. So here is because of the, again, change in the globulins. So I think these are all the conditions associated with altered binding of the TBG. So hyperestrogenic states like pregnancy, use of OC pills or tamoxifen, or other situations, and the decreased binding is seen. So where it can have a alteration in the T4 levels. So I think this is the two more case scenarios. So this is 10-year-old boy was evaluated for short stature with I think these are all the rare cases, but just to complete the abnormalities in the TFTs, I just added. So this is a 10-year-old boy was evaluated for short stature with behavioral abnormalities, mild intellectual impairment, and had a goiter. So T3 is elevated, T4 is elevated, TSH also is little elevated. So what is the diagnosis? So generally, see, look at the background situation. Okay, so it can be a generally very rare, but resistance to thyroid hormone, right? Because of the abnormalities, right? Resistance can be at the pituitary level, or it can be a generalized. If it is a generalized, patient will have a hypothyroid manifestations. If the only at the pituitary level, they can have a thyrotoxic manifestations also. But the close differential diagnosis is the TSH secreting tumor. So the difference is by doing the alpha subunit or the pituitary imaging where there can be a macroadenoma. And this is again very rare disorder. I was showing on the MCT8, right? So Allen-Dudley syndrome. So 5 years old with developmental delay, poor weight gain, spastic paraplegia was evaluated for thyroid, and T3 is elevated, but T4 is low. So there is a incongruent among the T3 and T4, and TSH is upper limit of the normal. So this is a very rare genetic disorder of Allen-Dudley syndrome. So I think, so to sum up, I think you are able to see, right? So you can see in the picture, so top free T4 and free T3 are elevated, TSH suppressed, that is thyrotoxicosis, and all the causes of thyroid. It can be Graves, it can be toxic nodular goiter, or toxic multinodular, or other, like it can be destructive thyroiditis or other causes. And the other, the right below is the free T4, T3 are decreased, TSH is normal or decreased. So that can be because of the central hypothyroidism or the non-thyroidal illness, what we have discussed in our case scenarios. And look at the free T4, T3 increased, but TSH is normal or increased. The whole list of the like it can be assay interference or the resistance to thyroid hormone as we have discussed, or TSH secreting adenoma, non-thyroid illness, or drugs. So again, the down is the hypothyroidism. And this is the subclinical hypothyroidism, T3, T4 are normal and TSH is elevated. But it can be like seen with the, suppose if it's a on-follow, poor compliance. So patient was non-compliant but started on treatment recently. So there is a normalization of T3, T4, but still TSH has to become normal. So this is free T3, T4 are normal, TSH decreased, that is the subclinical thyrotoxicosis. So I think this is an algorithm. So if any discordant TFTs are there, re-evaluate the clinical history. So age should be considered, any pregnancy, thyroxine therapy, and confounding medications like amiodarone, furosemide, heparin, steroids, dopamine, which all have an influence, and the non-thyroid illness. And again reassess the thyroid status. So, and if the again discordant, and exclude the assay interference, and rarely consider the genetic abnormalities. So take home points. So most often TFTs are straightforward, like very recognizable patterns, so to make an appropriate diagnosis, but sometimes it can be challenging. And when the TFTs are discordant or the incongruent, so consider the following. So clinical context and altered physiology like pregnancy or non-thyroid illness, and newly detected or the or already known disorder on treatment, or drugs like amiodarone, lithium, estrogen, glucocorticoids, all these things. And lastly, consider the assay interference. Thank you.